A very good evening, everyone. So we are waiting for some more people to join, and then we will start with the program. A very good evening, everyone. I'm Dr. Jyoti Vijay. I'm Assistant Professor at IIHMR Bangalore. Quickly, I would like to brief about myself that I'm PhD in food science and nutrition, and I did my education from masters in food science and nutrition, and then I pursued my PhD, and I worked, has experience of working with All India Institute of Medical Sciences, New Delhi. I also worked with IIHMR Jaipur, and from last 5 years, I'm working here in IIHMR Bangalore. So my core domain belongs from public health nutrition and the nutritional assessments. So with this, I would like to host today's program. So with this, I would like to take 2 minutes and I would like to brief about my institution. I hope my slides are visible to everyone.
Yes, ma'am.
Thanks, Arun. So just a second.
Yeah.
Yes, ma'am.
Thank you, Jyoti. We welcome Dr. Anjana, and we're very happy to host this program. And we welcome you, Dr. Anjana, and we're very, very happy that you are able to really join. And this is a very important opportunity for us, to learn from the vast experience of your clinical experience as well as from the institutional knowledge of Mohan's clinic. So thank you.
Thank you.
Yeah,
Ma'am, very happy.
Jyoti. Yes, thank you.
Thank you so much. And I also request all the participants to please type your name and with your organization in the chat box. So we would be able to hear from which organizations our participants are belonging, basically. So that will be great. Okay, so let's start with the brief about my institution. So first, I would like to brief that IIHMR Bangalore, which was established in the year of 2004, and these are our institution milestones, basically. So we started received AICTE approval for our flagship program, that is a postgraduate diploma in hospital management, in the year of 2010. Then we followed by NABET accreditation for NABH consultancy in the year of 2015. And then we have added one more program, specialization in the HIT. And then we have also received MBA equivalency for our program from AIU, basically. And then in the year of 2023, we have launched fellow program in the management. In this year, we have launched a postgraduate diploma in management in the area of artificial intelligence and the data science, which is a very unique program which is offered by the Institute of Health Management Research, Bangalore. So these are institution milestones, and these are different key verticals under which we are offering various programs and our training services and research and publications, consultancy services, and Center for Advancing Digital Health. So that's ADMIRE is our another vertical where we do some like incubation centers and innovation labs we have. So under the academic, basically, we offer, like we have a 2 years fellow program in the management, hospital management. So we have 4 specializations: hospital management, health management, public health, and the pharmaceutical management. So now moving further, these are our empanelments, national and state empanelments. Now moving further, these are like courses which I've briefed we have, and then curriculum like follow, and then we ensure a record of 100% placements for all the years across. So this is our approvals, and then moving further, these are our recent awards like Excellence in Hospital and Health Management. So Times of India 2024 recent award which we have received. And then these are our core domains, the areas where we are working in the area of research, like starting from the like baseline assessment to the implementation research and the endline assessment, program assessment, and then health system strengthening, nutrition, and maternal and child health. And we work in the area of tribal as well, and implement like development of IC materials. So these are our core domain areas also, and expertise as well. Now, moving further, IIHMR has a Center for Learning Development under which we offer programs like certificate executive programs, FDPs, short-term, long-term courses, professional practice series, and we also offer customized training programs. Now, this is our ADMIRE. So we have research and development under ADMIRE. So through that, various publications also like comes, and then Skilling Hub, DigiHealth Data and AI Lab, and incubation cells. So these are our various collaborations, like with we have collaborations with government departments, academic institutions, healthcare delivery, tech companies, and then like for learning and development, we have international and like national collaborations. This is our intellectual capital. So like these are our like all the like faculties and professors basically. Now these are our current programs which we are offering under the like Center for Learning and Development. So one is on advancing excellence in the area of clinical nutrition. So where we have already completed one cohort, and our second cohort is going to be released in this month only. So here we train all the healthcare practitioners, basically all those are from the allied health backgrounds also. So they this is actually building their skills for the disease management, starting from the weight reduction to the diabetes management to all the metabolic disorders, everything, and we cover into this. So how dietary management is very crucial for the disease management. And we also have we are launching a program on the public health nutrition, basically. So program management, starting from the nutrition throughout the life cycle to the how a program management, because government of India has already so many programs, and one dollar investment yields to the $16 in terms of a nutrition investment, basically. So this is how program management is a very crucial area where, this is program we started. Now moving further, this is about my institutions. With this, I won't take much time, and I would like to invite our director, Dr. Usha Manchuna. She's a professor and director at IIHMR Bangalore for the opening remarks and welcome of Dr. Anjana.
Yeah, thank you. Thank you, Dr. Jyoti. And I once again, invite and welcome Dr. Anjana. And this is a very important program. And I'm sure, anything that we have to do with, people's health, diabetes has become a major issue. And India has nobody has to speak about it. It's kind of with, a negative connotation that we have become the diabetes capital of the world. And I'm sure, just to set the context, and if we really look at, the numbers are a major challenge. So if we look at, there are about 800 million adults living with type 1 and type 2 globally, and with more than half not receiving treatment. These statistics, I'm sure, those who are in the healthcare are already very aware of. And there are, 212 million in India, that is 25%, and 148 million in China, according to the, new study as per the Lancet. So they say that it is much higher. So whereas ICMR India B 2023 report pegged for India at 100 million. So both the numbers are, whichever number we take, it's very high. So if we really look at going forward, Lancet indicates that about 1.31 billion will be living with probably diabetes by 2050 worldwide. So in 2021, type 2 diabetes accounted for 90% of all the diabetes prevalence, and most of this burden is attributable to social risk factors like high BMI, dietary risks, environmental and occupational risks, tobacco use, alcohol use, low physical activity. And so this is one of the major things that we have to look at. And also there is a lot of inequitable aspects which come into picture in based on when we want to organize our resources and want to help people, and whether it is to prevent or to treat, this becomes a very important aspect. So the other aspects of diagnostics and medical care, which is very critical, and I'm sure Dr. Anjana would be addressing that a lot more. And then lifestyle changes, which are easily said than done in terms of diet, physical activity, stress, and maybe the new thing that also adds to the stress is the screen time that may happen. And so the very important aspects of primary and secondary prevention is very, very critical. And how does the government policies and how does the public health system is geared towards. Then the last aspect is in terms of the public awareness, behavioral change communication. Can we start young? That means even from school age itself, can we really inculcate people with healthy habits? We all know that there is a lot of stress among youngsters, and therefore, from the early on, if we are able to put them on sports, put them on exercises, put them on physically activity, because now there is counteracting forces in terms of screen time, in terms of the mobile that students and children and everybody is using. So there is a lot of intervening factors. And one of the other toughest thing that I'm sure Dr. Anjana would be addressing is also the adherence to medical treatment. Coming from families in a bigger city like Bangalore, we keep hearing, and I kind of heard very interesting things that when they come for any party or something, many people end up eating more number of sweets, the way we have changed our lifestyle and even in partying and various others. And then they think that it's okay to eat today and take one more pill for diabetes. So I think I set the context with this. And, therefore, in terms of really looking at how do we really address this, it is a big challenge. And we're all party to it. We all have to really work towards addressing this. And we also have a lot of students from IIHMR who have joined, and they're going to be, at some point at various levels, working with hospitals, working with other healthcare organizations. And I'm sure, diabetes is a major, major thing that they will also be helping, in terms of the patient side as well as from the provider side, and supporting at various levels. And I think this is a great opportunity to learn from the experience of Dr. Anjana on the various aspects of, how do we really now look at diabetes care? What is that we really need to do? Medical aspects and other aspects. And so I'm very happy, and thank you, Dr. Anjana, for accepting our invitation, and over to you now.
Thank you so much, ma'am, for setting the context for this outstanding webinar which we have today. And with this, I request my IT team to launch a poll. So we have some exciting activity for our participants. So Arun. Yeah, so the poll is already there. So are you able to access this poll? Yes. Now we are getting the responses. Like the first question is, polished millets have a higher glycemic load as compared to whole millets. Okay, so participants are saying true, yes, yes, okay. We are getting a good response. Wow. So our participants are aware about the millets and which are the polished millets, and then which are the whole millets where they've not debrand basically. Okay, some of the participants doesn't agree with that also. Okay, our next question is about people with diabetes must completely avoid all foods containing sugars. Okay, so this is the response we are getting. Some are saying yes, 40%, then again 60%, 64%. It's a false. It's a false. Okay, okay. So we are getting a mixed kind of a feedback from our participants regarding this. Okay, our next question is about protein intake has no role in the management of diabetes. Okay, so most of the participants are agreeing that there is no role, there is no association between the protein intake and the diabetes management. Does it? So I think these questions will be getting answer from our Dr. Anjana's session also, whether protein has any role. And also I can also discuss later on about this also. Okay, but nice. We are getting a good response from our participants, and this count is yes, rapidly increasing. Okay, next is regular exercise only helps in reducing weight, not ensuring the optimum blood sugar level. Okay, is it? So some are saying yes, but majority of the population, they are saying that our participants are saying that this is not right, because okay, they are saying that regular exercise helps in reducing weight as well as it also ensures the ensuring the optimum blood sugar levels. Okay, so let's see. Now, what is the next question? Eating too much sugar is the sole cause of diabetes. Oh, so 80% are only agreeing that this is true, but 82% participants are saying that no, this is not only the sole cause of diabetes. There are other causes which are also for the diabetes. Okay, what's the last question? Last question we have is like an irregular sleep cycle has no impact on overall health. Okay, so cycle has an impact. If sleep hygiene, does there any sleep hygiene or sleep cycle has a role on the health? So like most of the 75% of the participants, they are not agreeing for this and they are saying it's a false. Okay, so let's see. The count is increasing and I think 60%, 60 participants have already attempted this poll. But yes, the count is increasing to 72. Okay, it's going, the number is rising. 75, we can see. Yes, but this depicts that are like all the participants, they are interested in this and they have us they are aware about diabetes actually. Okay. So as of now, the count is 84 participants have already taken the poll. Okay, let me know when you Arun, when the poll is over. So I think we can end the poll because there is a saturation level where 86 participants have already, now the number is not increasing. Okay, 87. Okay, Arun?
Yeah, can I share result now?
Yes, yes, you can share the results. Okay, so this is the correct answers. So for the question 1, yes, polished millets have a higher glycemic load as compared to the whole millets because we are removing the fiber, and there is a study which has conducted which has shown the positive result that if you are eating a polished, non-polished millets basically, then they have a lesser glycemic load because the fiber is there, so that actually delays the digestion and absorption basically. Okay, next question is people with diabetes must completely avoid all foods containing sugar, and this is it. The correct answer is false, because you cannot avoid all all sugars, because we need a carbohydrate for our body, and that is a very essential part. So we need a balanced amount of carbohydrate to manage the diabetes. Now, protein intake has no role in management of diabetes. Okay, the correct answer, this is a false actually. Yes, protein intake is associated with the management of diabetes, whereas Indians has a lesser protein intake, but while ensuring the quality of the protein and the amount of protein which we are eating, which is less, and that protein intake is directly related with the ensuring to keeping the blood sugar levels normal. So protein has a direct role. Okay, regular exercise only helps in reducing weight, not ensuring the optimum blood sugar levels. I think this is very much clear. The answer is false. Actually, exercise is very important for the diabetic patients as well. It's like excessive workout or the high intensity workout is helpful for reducing weight, but daily exercise is crucial for the diabetic patients. Now, eating too much sugar is the sole cause of diabetes. I don't think so, yes, because there are various other causes like your sedentary lifestyle, and then the lifestyle plays a very crucial role in this. And sleep cycle is always associated with the overall lifestyle management. So sleep cycle does affects to our health. Okay, so this is how I'll give a sessions to Dr. RM Anjana. So first, I would like to introduce Dr. Anjana. So just a second, I'll be sharing my slide and then I'll hand over to Dr. Anjana. So Dr. RM Anjana, she's the managing director and of Dr. Mohan's. I hope my slides are visible.
Yes, ma'am.
Yeah, okay. So Dr. RM Anjana, she's the managing director of Dr. Mohan's Diabetes Specialty Center, and she's the president of the Madras Diabetes Research Foundation. Her main research areas includes diabetes, epidemiology, physical activity, and translational research and metagenomics. She has conferred with prestigious fellowships like American College of Physicians and the Royal College of Physicians, Indian College of Physicians, and Fellowship of the American College of Endocrinology. She also serves as a PI and co-PI for several national, international projects. And she has in her profile, more than 396 articles in the national and international peer-reviewed journals. Dr. Anjana, she is an expert panel member of the WHO Selection and Prioritization of Global Diabetes Monitoring Framework, Health and Wellness Center, and a member of the Scientific Advisory Committee of the ICMR, National Center for Disease Informatics and Research. She's also adjunct faculty, at IIT Madras, and she's a part of the expert committee for development of NCD protocols for the IIHMR Bharat Health and Wellness Center, and she's a member of the International Diabetic Federation Atlas 11th edition, Diabetes-Related Mortality, and which is a special interest group. And she's also a technical expert member of the WHO Global Framework Indicators for Tertiary and Secondary Care. So, with this, her profile, I would like to hand over the session to Dr. Anjana. Over to you, ma'am.
Thank you so much, Dr. Jyoti and Dr. Usha. It's an absolute pleasure to be here. I'm astounded to see so many children, students here today. I see online so many. I see a room full of people here. So I really hope that they would benefit from what I'm saying. So today I'm just trying to share my screen. Just 1 second. Yeah, can you see this?
Yes, ma'am.
Yes.
Okay, perfect. So I'm talking about diabetes care redefined, thriving, and not just surviving. I really like that topic, Dr. Jyoti. So I think let me try and do my best. I'm part of the Dr. Mohan's group. We are the largest diabetes center globally with 650,000 patients that we cater to over a 30+ year period. So we do a total diabetes care, which not just involves diabetes care alone, but we also, for a patient who walks into a Dr. Mohan's unit, we are across Chennai, Bangalore, Hyderabad, Kerala, West Bengal. And so all over the south and the east, we do have 50 centers in 32 cities. And for us, any patient walking into a Dr. Mohan center is not just given a medication prescription, but we also give a diet prescription. And for the very first time in a diabetes center in India, we give an exercise prescription. So when I saw a question on exercise, I was really, really happy to know that most people do know the importance of exercise, because for diabetes control, 4 pillars have to come together. One is diet. The second one is physical activity. The third is, education and awareness about diabetes. And only the fourth pillar is medications. And that's the only thing that we doctors do. The rest of it are done by people interested in lifestyle. So my talk today is I don't have any conflict of interest to declare. 1 second, my slides are not moving. Yeah. But this presentation does contain unpublished data, so please do not take photographs or copy this in any way. So this is the flow of my presentation. I'm going to have 3 components to this as requested by Dr. Jyoti. The first one is epidemiology. And I'm so happy that Dr. Usha brought up the differences in numbers that has become a recent controversy. I'll be talking primarily about the ICMR India Diabetes Study, or INDIAB study for short. That is the national study on diabetes in India. I'll talk briefly about therapeutics and technology. So let's move to the epidemiology of diabetes in India. The ICMR INDIAB study is funded by the Indian Council of Medical Research and the Department of Health Research, Government of India, and is clearly the largest epidemiological study on diabetes ever done. The primary objective was to determine the national prevalence of diabetes and pre-diabetes. But in India, health being a state issue, in order to get a national prevalence, one must have state-by-state data. So we have data from every single state, union territory, and island in this country. We also look at prevalence of other comorbidities, hypertension, dyslipidemia, coronary artery disease in the country. It's a cross-sectional, door-to-door survey of adults aged 20 years and above. Ma'am did mention about the national numbers of 101 million, and that comes from this publication, the INDIAB 17, that was published last year. So in that paper, this is what, these are our numbers, national numbers: 101 million with diabetes, 136 million with pre-diabetes. Our hypertension numbers stand at 315, and our biggest numbers are of course obesity, with abdominal obesity being at 350 million people. So these are huge and staggering numbers for the country. Now, this was published in Lancet Diabetes Endocrine 2023. But this year, the main Lancet published another collation of data, of which I am also primary author, another collation in which they declared the India numbers to be 212 million, which was actually a doubling of this. So there was a hue and cry saying, how can in 1 year a doubling of numbers happen? Well, just to clarify, there was no doubling of numbers. The global study only took numbers from the INDIAB study, but the way they have looked at it, for example, here, when you say 101 million, these are based on glucose values from an oral glucose tolerance test or an OGTT, and that is the correct way of doing it. But other than in India, people actually diagnose diabetes using a HbA1c test, and thus, in order to globalize the numbers, the authors in the main Lancet used the HbA1c test. And if you do that, there will be an artificial elevation of numbers in South Asia, and that's what happened to India. The 202 million is when you take A1. In fact, the numbers are from INDIAB. In the 17 publication, INDIAB 17 publication last year, we have published both prevalences by A1C and by glucose. But we took the glucose numbers for extrapolation into burden. They took the A1C numbers for extrapolation. That's all. There's just a methodology difference. The ministry has not accepted this. So they have asked for an addendum to come in, wherein, because there's a hue and cry in the country, there's no 202 million. It's just the way they have declared through A1C or through glucose. The numbers still stand at 101 million. So this is the prevalence of diabetes based on the glucose results. So the overall prevalence of diabetes is 11.4%. If you look at these, urban areas have double the prevalence as compared to rural areas, and that's quite important to see. Now, if you look at it, these are color-coded maps in every state in the country. Red is a prevalence of 10% and above, and green is less than 5%. Yellow and orange are in between figures. You'll see that overall for diabetes, the southern regions have a lot of red and orange, whereas the central regions, especially in rural India, there is some green and yellow. Urban India is almost entirely red or orange, which is not very telling for the country in terms of its disease burden. Now, if you look at it by age and by urban rural, so people ask us, where is the takeoff point for diabetes? Where does diabetes start? From INDIAP, we have shown that diabetes in this country starts in the age group of 25 to 34 years. So that's really young adults, people like you who are exposed to diabetes, starting getting diabetes. And it doesn't matter if you're a man or woman. It doesn't matter if you live in urban or rural area. Overall, the numbers look the same, however you look at it. Now, any Caucasian population you take, you will see a shift to the right by at least 2 decades, where diabetes starts only after 50 years. For us, it's like 20, 25 years. Our young adults have started having diabetes. This is another very, very important publication. This is INDIAP 13. It came in 2017. So what we did here, this is socioeconomic status in the pink and blue bars. The pink are the lower socioeconomic status and the bluish bars are high socioeconomic status. Now, the urban and rural panels are shown here and the states are listed here. There's 15 states. This is earlier publication. So here, if you look at it, in rural India, we've always been traditionally taught that diabetes is a disease of the rich, right? Higher socioeconomic status, higher diabetes, and that holds true even today in rural India. But if you look at urban India and you look at high GDP states, the richer states of the country, you will see that a transition, what we call as a demographic transition, has happened, wherein the actual richer people have less diabetes, and this is moving to lower socioeconomic groups. Now, this becomes a problem for two reasons, because these people have lower literacy, lower accessibility, lower availability of care, and the inability to actually take care of themselves. This becomes a huge problem. Now let's move to pre-diabetes. As we all know, in the causal pathway, nobody gets diabetes, although it does seem that overnight someone can get diabetes. Nobody actually gets diabetes like that. There is a pathway in which someone becomes normal, goes through the state of pre-diabetes, and only then goes to diabetes. So traditional teaching is that 1/3 of people with pre-diabetes will progress to diabetes, 1/3 will stay pre-diabetes all their life, and 1/3 will regress to normal. So that is traditional teaching of the West. In India, from studies done before, we know that 60% of people with pre-diabetes progress to diabetes, and they'll do it within a 5-year period. Now, knowing that information, let's look at the national numbers of pre-diabetes. There are two very striking things in this slide if you compare it to the previous slide. The first is the numbers are higher than the diabetes numbers. So you do have an overall prevalence of 15% as opposed to 11% of overall diabetes. The second most striking thing is look at the urban-rural differences. There are none. I started by saying that the diabetes in urban areas was double that of rural areas, but look at pre-diabetes. They're equal both in rural and urban areas. Now, why is that important? Now, remember we said that 60% of all pre-diabetes becomes diabetes. That becomes really important because the absolute number of people living in rural areas, 70% of India lives in her villages. So if you get more and more pre-diabetes there, this is like a ticking time bomb waiting to explode. All of these people are going to convert to diabetes in the near future, in the next 5 years, and you're going to have a number of people with diabetes without being able to have a rural health system that deals with this phenomenon. And that, I think, is a very scary thought. So here are the pre-diabetes numbers. Look at it. There's no green anywhere. There's hardly any yellow. In fact, the only yellow you'll see is already in states that have transitioned. So that those that have very high prevalence of diabetes have lower prevalence because it's already converted. So that's the only yellow. But look at the country. Also note that in the central regions, remember, we had a lot of diabetes. The green numbers, all that has turned into red right now. And so the number of pre-diabetes is alarmingly high, telling us that diabetes numbers in the near future is going to increase. Now, we have a lot of diabetes. What about A, B, C control? A stands for A1C, a HbA1c test. We all know that a good control of diabetes is defined by an A1C of less than 7%. So how many people actually achieve this among those with diabetes? We only have about 35%-ish in both urban and rural areas who actually have their diabetes. So we have a lot of diabetes and we have a lot of people without good control of their diabetes. If you look at self-monitoring, now this is something that's really important for someone with diabetes. It's a marker of self-efficacy. You come and see the doctor a couple of times a year. In between, the diabetes control is in your hands. So unless you have a way to measure, and the simplest way to do that is a self-monitoring through a glucometer, I'm sure you're quite familiar with that. It's quite low, both in urban as well as rural areas of the country. Now, B stands for blood pressure. How many people have a blood pressure less than 140/90? It's about half of them. So about 50% of people have their blood pressure under good control if they have diabetes. C stands for cholesterol. And here you have total cholesterol, triglyceride, and LDL. The LDL control is about 40% overall. So suffice to say that we're doing worst with glycemic control. We don't have enough number of people with good control. We're doing slightly better in the BP and cholesterol regions. Now, what happens if your diabetes is not under control? You get complications, of course, and you have the microvascular and macrovascular complications. So macrovascular is big vessel disease like coronary artery disease and peripheral vascular disease. Microvascular is small vessel disease as defined by retinopathy, nephropathy, and neuropathy. Given here are the numbers from the CURES study, where we have both urban and rural prevalences of all of these diseases. And well, I think the important thing to note is that a large number of people will start getting complications if their sugars are not under control. So now think about it. A large number of people with disease, 60% of them don't have any control, and then a quarter of those going into complications. And all of this, say, each one takes about a 5 to 10 year period. So suppose you start at age 25, by age 35, you're having, let's say, early disease. One of these are hit, your kidney, your eyes, etc. And then in the next 10 or 20 years, so by 45, 50 years, you've reached end-stage disease. Imagine. So that is the kind of problem that this country is going to face unless we do something about it. The do something about it goes around our lifestyle factors. And there was a lot of talk about diet earlier. So let's look at carbohydrates. This is from the INDIAB. This has been submitted to Nature Medicine and is under review. It tells us how much carbohydrate the country is consuming. Overall, the country consumes about 70% carbohydrate in anything you eat, whether it's roti, noodle, rice, pasta, whatever you take, it's carbohydrate. 60 to 70% of anything an Indian eats is carbohydrate. There's also a lot of talk about vegetarianism in the country, saying that there's a lot of vegetarian. There isn't. There's only 26% vegetarian overall. But does that mean that it meets the protein requirement of the country? That's not true either. So funnily, although all of us say we are non-vegetarian, the frequency of this non-veg is inadequate to meet protein consumption, because people who eat non-vegetarian eat once a week, once a month, and then there is all this fasting and festivities and things like that, various months, various days where they can't eat non-vegetarian food. So actually, the protein intake is rather deficient. The carbohydrate here, if you look, the white areas are rice-eating states. So you'll see southern and eastern regions eat more rice, whereas the brownish areas, the central areas are your chapati wheat. The reddish areas are the millets. So the millet consumption is really small across the country. And like was discussed very well earlier, I don't think I have those slides today, but we have electron microscopy photos of millets that we got in the market and compared them with the actual whole grain that you get from a farmer. And you'll be quite surprised to note that every grain that is available in the city, we did it for Chennai city, must be the same for Bangalore and other cities, was refined. So if you have these millets, your sugar actually goes up. While the year of millets was declared the healthiest thing, it wasn't so because of the very high GI that comes after refined millet consumption. So this is what happens to you if you eat risk of diabetes with rice as a staple food. Your risk of diabetes, if you eat large quantities of rice, which we do eat, is 326 grams is the last quintile. You'll see that you have almost a 1.8% risk of developing diabetes. So then you'll ask me, ma'am, maybe wheat is then the answer. If you can't eat rice, this is the risk for diabetes with wheat. It's actually higher than rice. And the reason for this is, again, pretty much same like the millets. The wheat is all fine as long as it's a whole grain. It's how it's consumed. Today, we have chakki fresh atta, which has very small grains and thus has a very high GI. So the refined wheat that we have today is actually worse than rice in terms of its risk for developing diabetes. So the whole story on the carbohydrate is it doesn't matter which type of carbohydrate you eat, as long as the quantity is under control and the quality is under any type of whole grain is good. Overall quantity of carbohydrate needs to come down and the quality must be looked into. Avoid refined carbohydrate. Now, fruit and vegetable, I always talk about this. The WHO says that we have to take 5 servings of fruits and vegetables in a day for metabolic health. The national average is 2.3. Whether you're man, woman, urban, rural, it's a shame. We don't eat enough green leafy vegetables. So our fiber content is rather low across the country. And because of that, if you eat less fruits and vegetables, you have more risk for diabetes. Or the other way of saying it, the more fruit and vegetable, the less risk for diabetes, both among men and women. Nuts. There's a lot of talk about nuts and especially cashew nuts. So the Cashew Council came to us and asked us about, whether consumption of cashew nut was actually good for you. So we did a huge randomized controlled trial, which looked at cashew nuts. And this was the conclusion. This has been published in Journal of Nutrition in 2018. And what we show is that a handful of cashew nut in its whole form, without processing, without salt and without oil, has some beneficial effects on HDL and systolic blood pressure with no deleterious effects on weight, lipid, or glycemic measures. So it has no effect on glycemia or lipid, but people worry that if they eat cashew, they gain weight. That's not true. We disproved that. The other good one that came by was almond. Almond also helped in weight loss. It improved insulin resistance, and the cholesterol also improved. No effect on glucose or lipid parameters. There was some effect, very minor, on waist circumference in this. Fats and oils, always a big question here. So in Tamil Nadu, we find that there's a very high consumption of sunflower oil, but unfortunately, the sunflower oil is the worst in terms of all metabolic risk factors, whether it is glucose, abdominal obesity, or hypertension. It has the worst risk. The traditional oils, groundnut oil, sesame oil, mustard oil, rice bran oil are way better, and mixing up these oils for various things do have a better risk on metabolic health than just consuming one oil alone. Physical activity. This is an earlier publication that came from India. And this data is unpublished. It's from all 31 states. And we show that activity levels are terribly high in the country. In urban areas, 71% people are completely inactive. But what's even more surprising is that almost 60% in rural areas. So we still imagine people being very active in the fields in rural areas. Not anymore. With combined harvesting, with all kinds of things that have happened, rural areas are also becoming highly inactive. And your activity level. So again, this is the WHO here that recommends, 150 minutes to 300 minutes per week of moderate to vigorous intensity activity. Overall, 10% of males and 3% of females meet these numbers. We're just really, really bad in terms of our physical activity level. This is not even 300. This is 150 cutoff. So if you put all this together, this is a heat map in which you can say that, okay, so if you look at, so sorry. Yeah, okay. So this is a heat map where you have the states on the left listed below for you to see. And you have all the various things, A1C, BP, whatever, smoking, alcohol, and then they're color coded. If they're within the normal, it's green, and then orange is like it's a traffic light, and red is the worst. So you can see that for physical activity, there's a huge red, the last column everywhere. And then triglycerides is somewhat there. We're not so bad with blood pressure so much, diastolic blood pressure, total cholesterol, we're actually there. But the one glaring thing here is fruits and vegetables, which is in orange, and physical activity, which is in red. So what can we do about this? We have shown and published before that just taking diet and physical activity alone, just these two things, can at least theoretically prevent 50% of diabetes. And this is much better. Actually, the effects are much better in women than it is for men. So we then went on to publish what are the dietary recommendations for prevention and management of diabetes. And here they are. These are the current intakes of the population. 62% of everything we eat is carbohydrate. Protein is at 12%, fat is at 25%, and fiber is at 3.5%. So in order for you to either remit diabetes if you're newly diagnosed or prevent progression, either ways, one has to bring down the carbohydrate from 60 to 50% or from 70 to 50%. So 50% of everything you eat has to be carbohydrate and not more. So people talk about very fad diets, right? Very big restriction and carbohydrate, bring it down to 10%, 12%, not needed. Even if you just bring it down to 50%, we're good enough. So once you get rid of the carbohydrate, what will you replace it with? That becomes really important. Do not replace with fat. Fat is good at 25%. It stays where it is. So you must replace with protein. Protein, which is 12, needs to go to about 20%. And fiber, which is at 3.5%, needs to go to about 6%. So we need a doubling of protein and fiber. So fruit and vegetable, remember we talked about that, and protein intake. These are the two things. Protein in any form, vegetarian or non-vegetarian protein, needs replacement. So bring down carbohydrate and replace it with protein. That's a very simple thing to remember. Now, physical activity. This is the WHO latest recommendation. It talks about 300 minutes. India, we don't even meet 150. So 300 is so, out of the thing right now. So in addition to 300, we must do at least on 2 to 3 days a week some strength training, which involves all the major muscles of the body. So people in our country, the minute you start saying strength training, they're thinking of gym body, going to the gym. Only men isn't so. We're just talking about muscle strengthening. It's absolutely essential for men and women of any age. And the new one is sedentary time. I think Dr. Usha was talking earlier about the sedentary time. We just published on children, just came out a few days ago, where we talked about screen time in children being the biggest cause of sedentary behavior, sedentary sitting. So screen time in children being the biggest cause, no different in adults. 65% of all sedentary time is now being attributed to screen time and social media use. So this is becoming a big problem. So the simple message here is put your phones away, focus on where you are at the present, move around as much as you can, and do 1 hour of physical activity of your choice every day, and that'll take care of your metabolic needs. So these are some, publications that we had about people. I was so happy to hear as far as the exercise part was concerned, everybody knew that exercise was needed and beneficial. That's precisely what we showed here as well. Most people knew that it was a great thing to exercise, but there were many barriers. Now, if I ask the people here, how many of you actually exercise? It's good for you, but how many people actually do exercise? Well, then that's going to be less than 10%, as we have shown in our national studies. So the reasons for that are many. Okay, and here the women are in white and the men are in blue. And you'll see that women just don't have time for anything and have like a million reasons not to exercise every day. So we then started, I've been working on this for about 15 years now, trying to ask the question, how do we get women to exercise? And we came up with multiple things for a woman to accept an exercise intervention. It has to be innovative. It has to be interesting, sustainable. It has to take less time. Time is very important for women. It has to be socially acceptable. So we went on telling people, do exercise, go to gym. It's not really acceptable in our country, especially leave urban, rural areas, anywhere. You ask people to go to gyms and things. Women are not allowed there. Girls are not allowed in playgrounds. She can't go outside at 6 p.m. So you need a form of activity that is socially acceptable in our country, can be done at home, and fun. So, ladies and gentlemen, I'd like to introduce you to Tandav, which is a woman specific physical activity intervention that we came up with. It was a concept which we looked at combining dance with physical activity, high intensity interval training, or HIIT for short. We looked at trying to actually improve fitness in women, but women were so unfit in our country, they couldn't do high intensity interval training. So we actually had to go to girls, adolescent girls, 10 to 17 years is what we tried. So we first started this in a pilot mode where we took a small number of girls and tried to get the routine done. 23 girls aged 10 to 17 years. We had to see if it was safe. We looked at heart rate, VO2 max, blood pressure, ability to perform, etc. We did this with St. John's Institute, Bangalore, actually. And this was the publication that came from there. There were three things that we showed. One is we were able to keep the heart rate up. So just doing a 10-minute Tandav routine gave the children the metabolic benefit of doing 60 minutes per day, 6 days a week. They only had to do 10 minutes 2 to 3 times a week, and they were dancing. They didn't even know that they were exercising. Their heart rates went up, stayed up, their energy expenditure met HIIT norms, and they loved it. They taught their friends, and their friends taught their friends, and they were performing at Diwali and Puja and whatnot. It was an absolute.
Is a novel concept of physical activity aimed specifically at women and girls. So what is it? It is a concept which combines high intensity interval training, which is a certain type of exercise in which you do high intensity exercise for short periods of time and get all the metabolic benefits that you would get with a longer period of activity. So that's high intensity interval training. If you combine that with dancing, this concept is called as Tandav.
The Tandav dance routines generally include Indian film music, folk songs, regional music, and some Western songs that South Asians generally vibe to.
It essentially is high intensity dancing. It's simple, it's repetitive, choreo is very innovative. And why is it very special? Because the minute you say dancing, it brings a smile on the lips of most people. People connect with music, and then you start having this whole feeling of wanting to do this exercise.
Ladies and gentlemen, that is Tandav. We have reached out currently to 10,000 women and girls across the country and abroad. We've been to the UK, we've been to Australia, we've been all over the world, and girls and women absolutely love it. So these are performances by our children. Some of them are type 1 children. It's the first of its kind. To do this, we found that women find a happy and sustainable way to keep doing physical activity that gives them cardiovascular benefits and long-term NCD prevention. We have classes in online and offline mode. I'm sorry, it's not on Saturdays anymore. It's on Friday evenings. Our offline classes are from 5:15 to 6:15, and online classes are from 6:30 to 7:30. Every Friday, we have Tandav classes going on. Right, so that finishes the epidemiology bit. I'm going to take you through the therapeutics and technology really fast. So I understand that the latest therapeutics is something you just want to know. I'm just going to go through really fast. We have newer anti-diabetic agents, which are non-insulin agents. This include the SGLT2 category, the GLP-1 receptor agonist, and dual GIP-GLP receptor agonist, and we have the imiglamin. Newer insulins are the rapid acting insulins and the ultra long acting insulins. So SGLT2 is a protein that is found, SGLT is a protein that is responsible for glucose reabsorption. If it's found in the kidney, it's called SGLT2. And if it's found in the intestine, it's SGLT1. So what we have, so this reabsorbs glucose into the bloodstream. So an inhibitor of this protein will allow the glucose to go away, especially if you take SGLT2, all the glucose doesn't get reabsorbed into the bloodstream, it goes into the urine. So these drugs are really, really useful. You would have heard of these. Dapagliflozin, canagliflozin, EMPA, and remogliflozin are now available in India. They bring about a good A1C reduction of 0.1 to 1%. They don't have any hypoglycemia. They are very well tolerated, and they have a good weight loss of about 2 kg. It can be used in any stage of diabetes. In addition, so there is, with SGLT2, there is a risk of genital mycotic infections, which is more in women than in men, but generally well tolerated. At the moment, they also have extra pancreatic effects. They have good effects on the heart against heart attacks, heart failure, and CKD. And the drugs that are responsible is basically dapagliflozin and empagliflozin, along with cana, that do have. They have weight loss when you give them for diabetes, but they are not approved currently as weight loss agents. The next one are GLP. So these are part of the incretin group. So these are little mediators that are released when food comes in. They are sensed, and these incretins are released. So GLP and GIP are found in the gut and help to get pancreatic release based on the glucose level. So depending on your food, they are released and glucose comes out. So that is the action overall. Naturally in the body, we do have GLP, but these are GLP agonists, which are about 1,000-2,000 times at supranormal levels. So they have a very good action in not just diabetes control, but today they are becoming huge weight loss agents. So these are the drugs you would have heard. Semaglutide has now become the hue and cry everywhere. In India, we have oral semaglutide, but injectable weekly semaglutide is become the fad all over the US. We do have liraglutide, lixisenatide, exenatide. So all of these we have. They're not very popular because they're injectables. Until the weekly semaglutide came, we did have it, but people didn't want to take it. It's expensive. It does have some side effects, especially GI effects. And because you have to keep injecting mostly every day, people were not taking it. But now, with the injectable semaglutide weekly that is coming with huge amounts of weight loss, it's become the fad everywhere. There are extra pancreatic benefits, the first one being obesity. So you have huge weight loss, more than 15% weight loss we have with semaglutide. Now, you also have effects on the heart and the kidney, which are good with semaglutide. The other one is a GIP-GLP combination, and that's just come. It's called tirzepatide or Mounjaro. It's been approved in India. It's not yet come. We expect that it would come in February. Again, injectable. The weight loss is supposed to be fantastic because it is, of course, a GLP and GIP combination. But there are side effects. The GI side effects are a lot. We are hearing multiple things. We don't know yet. There's been some ileus and all, which are very serious, life-threatening problems. We're not sure. There is also a risk of retinopathy that has come. It's not on the package insert. It's not yet there, but there have been people who have had severe vision loss with semaglutide. But it is rare. There are multiple people across the world taking semaglutide without many, but these do exist. They have been reported. The A1C reduction is good. The weight loss is even better. We then also have imiglamin. So, this I finished. This is GIP-GLP. Sorry. So you also have the tirzepatide trials. I don't think you need to go through this. Yeah. So we have imiglamin, which is a mitochondrial modulator. So what it does is that it helps to block gluconeogenesis in the liver and increases glucose. So it works on both insulin secretion and insulin sensitivity, and that is a rare combination. It's an oral agent given twice a day. It's approved in Japan, and recently it's available in India, but it is new, and we do not know yet its effect on renal and hepatic insufficiency. We now move on to the newer insulins. So these are the faster than fast acting. There's Fiasp and there's Lumjev. So they have immediate action. You can inject and eat the food immediately, and immediate within a few minutes, you do have the action that's come in. But that's not the fad. Again, the fad now is Icodec, which is ultra long acting. So you give this injection once a week. It's not yet come to India, although it will come soon, is what I hear. You give this once a week, and that will take care of your instead of taking everyday insulin, multiple day insulin, you can just give this once a week. But of course, it doesn't work for everybody. There's just a few groups of people for whom this will work. So I don't have to take you through the structure of Icodec. It's been approved in US and Europe and Canada. And we hope that it will come to India soon. It has the lowest risk of hypoglycemia of any insulin. So that's the therapeutics. The last part is technology. We have a lot going on in the tech space for diabetes care and treatment. You probably have heard of these AGPs, which stand for ambulatory glucose monitoring. It's actually a continuous glucose sensor that helps you put your glucose values of 14 days into a pictorial representation. So it's a flash glucose monitoring system in which, see, just look at this. It's so easy to read. There are two lines here between 80 and 180 here, and this is the target. And your median band is the dark blue line, and your standard deviation are shades of blue. So you can see that the overall line and time is on this axis here, as you can see. So on your x-axis, you can easily make out when someone is below. So at 6 p.m., this person's sugar is at target. Sorry, 6 a.m., person's sugar is at target. It goes out of target after breakfast, comes down again after that, and then evening it's going up. So it's very easy for the doctor to see. So we have what is called as time in range. The percentage of time that a person has to spend within that band is called time in range. That correlates to, if you have about 70% time in range, it correlates to about an A1C of 7. No need to know all these, just the different bands that we have to treat. Now, this is a normal person. Without diabetes, your glucose readings would look like this. It's very much, can you see the band? And you can see all of the glucose readings are within that band. So that means this person is normal. Type 1 diabetes looks like this. It's all over the place. This is what we have to deal with. So a diabetologist's job is getting a glucose value that looks like this to start looking like this. And trust me, it's no easy job. So the sugars are fluctuating all over the place. This is day by day that you can see in the AGP report. The reds are the lows and the yellows are the highs. So this particular individual, you can see it's all over the place. Some days are high, some days are low, and very few days are actually normal. Time in range is about 41%, which is very inadequate. This is a person with type 2, mostly high here, less fluctuation than type 1, but you can see definitely sugars are very high, as you can make out here, 400, 500 sugars and all over. Can you see? Mostly high, not many lows. This is actually easier to treat than the earlier one with type 1 that I showed you. The other new things that have come are insulin pens, insulin pumps that have come in. We have newer delivery devices, which are actually pain-free. They are able to measure the insulin that is given. Or the smart pens also have, it is connected with an app, and it can actually think and tell you how much to give next, because it knows how much you have delivered, how much you need, and if you give it some carbohydrate intake, it tells you. It also prevents hypoglycemia for someone older person with memory issues. It tells you how many times. There's a tracker on the pens. You can do that. These are very convenient, insulin delivery systems, adequate and very accurate kind of dosing, almost no pain, but they are expensive. They're definitely more expensive than the traditional insulin. The latest ones that we have are the artificial pancreas. The latest pumps that have come are fantastic. These are the history of pumps. We started with just insulin delivery. Today, we have the 780G pump, which can actually, it has a sensor. It talks to the actual pump itself. So it constantly, every 5 minutes, is measuring the glucose value, giving an input to the pump. So before a patient's sugar goes low, it shuts off delivery. Before the patient's sugar goes high, it gives extra insulin. And it's beautifully navigable. Human beings don't have to do anything. The pump just does everything on its own, and it keeps your sugar within the time and range. These are an actual revolution, especially for those with type 1 diabetes. So all you have to do is give the carb count, and the rest of it the pump does. The last part is about the digital apps. What we use at Dr. Mohan's is called as 3D Digital Diabetes, launched on October 2022. So we use artificial intelligence for diabetes patient care. The first one is called Dia. She's a WhatsApp-based technical staff. And what she does is she gives you information on diabetes. So anything related to diabetes, it can be from a patient, a provider, just about anybody you want to know, this Dia is able to give you. So there are myths, there are things that, so it's a chat. So you ask questions and she gives you answers. And then if she doesn't know something, she connects you with a human being, or she finds out and she knows. And because she's artificially intelligent, she learns from the more questions that people ask her, the more she learns. The second one is called Diala. So this is a diabetes lifestyle assistant. I think these numbers are outdated. There are more than 1 lakh users with Diala. Now, these are just the patient app. This is for patients. So it helps to book appointments. It has prescriptions. It has their reports. It has a diabetes shop. It can do whatever the patient needs. It's a connect between the doctor and patient. There we have 1.5 lakh of downloads with Dia and Diala together. So that's what the app looks like. You can put your CGM values on it. You can put your SMBG values on it. It has, of course, weight, height, physical activity, calorie trackers. It tells you glucose over time. It tells you your intake. It lets you shop anything related to diabetes. It helps you with. We have patients engaging with the app quite a lot, and they want to know a lot about diabetes. So our knowledge bank is the one that is used a lot. They also use it for everything else. We have shown improvements in A1C with use of Diala compared to those who haven't used it. So just to tell you that digital care is the future. The third one is called Diana, and this is for us doctors. So what all that type 2 diabetes is not the same. We have various types of type 2 diabetes. One is the insulin deficient type called SID, severe insulin deficient. The second is insulin resistant obese diabetes. Second is obese. The first one is thin insulin deficient. The first one is obese, insulin resistant. Then you have the age related diabetes, which is the old type. And then you have the combined. So the third is a new novel thing seen only in Asia, where you have a combined insulin resistance and deficiency. So it's like double trouble, double whammy. They're insulin deficient, plus they're obese. So they have insulin resistance. So all of these have differential risk for microvascular disease. They respond differently to medications. So this is the Diana app. Once a patient walks into the clinic and does, I showed you a list of variables there. It was like age, BMI, cholesterol, etc. Those tests are done. It gets automatically integrated with the patient, doesn't do anything, doctor doesn't do anything. It's automatically integrated from machine to machine. And then Diana is calculating the risk and giving us, the doctor, the subtype of diabetes, one of these subtypes, it is able to tell us. It also gives the doctor an individual risk of retinopathy and nephropathy for that patient in a 5-year period. It'll also give you some drug recommendations. So all this is used by the physician to deliver precision diabetes care. We're also showing good improvements in A1C if the doctor actually uses the Diana app. So I'd like to conclude by saying, I think I've shown you that the prevalence, not just of diabetes, but of all of metabolic disease is very high in our country. We do not have good control. Our risk factors are not ideal. We eat too much of carbohydrate and do little physical activity. This has to be reversed. Newer drugs are paving the way for better control and weight loss. Newer therapeutics have come in. Things like insulin pumps are really promising, and digital diabetes is the future of diabetes care. Thank you so much.
Okay. Dr. Jyoti, shall I come in?
Yes,
And,
ma'am. Yes, ma'am.
Yeah.
Yes.
Dr. Anjana, there are questions on some very important areas. So the way I'm going to kind of look at this, based on the 4 different aspects that you talked about, that is the epidemiology, the lifestyle, and then the therapeutics, and then lastly the aspect on technology. So I so far haven't seen anything on technology, but there are quite a few, I'm sure, medical doctors there, and there are some questions on the therapeutic aspect of it. So maybe I would first go for that directly. Would that be okay with you? Yeah?
Yes, of course.
Yeah, okay. So there is, a question on if a patient is having diabetes, hypertension, and cholesterol, and the doctor prescribed about 3 different medicines for diabetes, and temesartan as diabetic BP medication, and rosuvastatin as cholesterol medicine. Continuous use of medications, is that dangerous? So Dr. Sandra wants to know about that.
Continuous use of medication is certainly not dangerous. In fact, it is recommended. So the reason that we start the medication is because there is a disorder that requires treating. Things like statins need to be taken lifelong. In fact, they have shown that they are the single most important therapy in prevention of heart attacks. So much so that the now US recommendations are that once you start a statin, you don't even need to check after that. You just continue to take it over time. So absolutely not. There is no risk. Things like telmisartan, we may stop after a period of time depending on what we started it for, whether it was for kidney, whether it was for blood pressure, etc. Statins are usually lifelong. Diabetes medication, it depends on whether or not you have reversed the diabetes.
Okay. Moving on, there is one question on, by Dr. Amarjeet Kumar. Does CBD directly influence glucose levels or insulin production in individuals with diabetes, and how does it compare to standard medications?
CVD, cardiovascular disease?
Yeah, Doctor. Yeah.
Does CVD, cardiovascular? What is that?
Yeah,
It's like it's a some psycho. It's a CBD. It's a kind of it's a cannabidiol, a non-psychoactive compound, basically.
So I'm not aware that it directly influences diabetes risk, not to my knowledge.
Okay. So then there is a question on what are some effective lifestyle changes. We will take that maybe a little later. But then there's one important question which says that on the, in terms of technology, but say is in terms of, ethical considerations on using gene editing technologies like, CRISPR, so to treat or prevent diabetes. So
we don't have, so these are all in the pipeline. Today, we don't have the ethics around this yet, other than the fact that it's not allowed at the moment. But right now, there are guidelines being written up for these. And maybe in the next few years, we will have more clarity on this.
Okay. So one is on the, let's say, for example, if a woman is known to have diabetes and wanting to, plan for pregnancy, related to it, I also have another question is, what about the latest drugs, OHA, you mentioned? Can you please elaborate on the additional effects of scenarios like pregnancy, women, childbearing age, cardiovascular, and renal issues?
So there's a lot of controversy about GDM, diabetes and pregnancy. A lot of people do give metformin, especially the gynecologists like to do that. We do not do it. the hardcore diabetologists, endocrinologists, for us, insulin is the treatment of choice. If you have diabetes before pregnancy, then you must be on insulin before. Perhaps if you're on a pump, your life will become easier when you get pregnant. Yeah, the metformin is given nowadays, but there is still there was some doubt about prematurity. After that, there is doubt on the anthropometric indices of the baby at 2 years, 6 years, 9 years. There is abnormal fat respect. So the current ADA guideline is to give insulin for anything that is in pregnancy and lactation. Now, in case after that, the woman can't, or rural area, something like that, you can try. But if you give metformin during pregnancy, the current thinking is that it interferes with mitochondrial respiration of the baby. So that leads to abnormal adiposity during child growth. So this child is born smaller. So SGA is thing, and then there's a catch up in the first few years of life, which give it an additional risk because it's no longer exposed, right, after a period of time. So that gets hindered, and then that catch up weight towards puberty increases the risk of this baby to have metabolic disease.
Okay, the one other last question maybe I could take, for the medical part, which people have put is in comparing efficacy and safety profile of SGL2 and DPP4 inhibitors, which will be better or best?
They're actually complementary drugs. So a DPP4 and an SGLT2 are usually used in conjunction with each other. They work on different pathways and both have glucose control. So we use them together usually.
Okay. So again, there are a lot of medical questions. And is it necessary to add metformin with combination of other drugs? And going ahead, did myo-inositol helpful in diabetes?
So, the metformin, today's guidelines say that metformin is first line therapy for all types of diabetes. But I just showed you now that there were various subtypes, and we are in process of changing those guidelines. Metformin is not the solution for all. That's what it is today. But I think that will change, and soon we will be giving different people, depending on what pathophysiological issue is there, we will be giving the drugs. So metformin, primarily, if you're talking about weight loss or obesity-related diabetes, yes, it's a drug of choice.
Okay. So another is in terms of, diagnostic itself, or like say, recommendation, should we give what recommendation if who is with a fasting blood sugar normal, where only, postprandial blood sugar is higher?
Yeah, so it depends on how high it is. If it's in the diabetic range, they're diabetic. If they're in we have a lot of people with whom fasting is normal, but it'll be in the pre-diabetic range. Then that becomes what we call IGT, or impaired glucose tolerance. These are people with very high risk of conversion to diabetes. Starting metformin is not wrong in this category of people.
Okay. Do we have more time? Maybe there are a couple more questions on new drugs. So can you please give details on the newer drugs you mentioned in relation to LFT, RFT, and cardiac illnesses, example, indication, and contraindication?
Yeah, so I did talk about the heart and the kidney. That's where the trials have been. They're all liver safe at the moment. They work on the kidney. The SGLT2 all work on the kidney. The others work on the intestine. So we don't have anything related to LFT at the moment. They are kidney safe and they are cardiac safe, especially with heart failure and ASCVD.
Okay, so the next set of questions are, lifestyle or activity aspects of it. I thought Tando was a very great one. I'm sure people who sat probably were tapping their feet and really moving their bodies when that whole thing was played. So one person has asked, it is difficult for, coming up with, like advising people and on the lifestyle changes. So just a quick, maybe, advice from you?
On how to change lifestyle?
Yeah, just one quick,
My simple advice is do something you like. Pick one thing that you like and do it every day. Consistency is key. You can't do something, for a few days and then expect it to help you with metabolic disease. It doesn't work that way. If you do even small amounts of activity, but you do it every day over a period of time, even if you don't see weight loss or any other, you will see metabolic benefit. Body is very, very receptive to physical activity. So whatever, pick anything you like, just do it every day.
All right. Moving on, just the last few things on. Again, there is one question of is non-veg bad for diabetes? So, we keep on, we would always wanted to reassure or keep asking some questions. So I think this is also important that people get that. Yeah.
No, non-vegetarian is not bad. We recommend chicken, fish, and egg for patient egg white primarily for patients with diabetes. This is a good source of protein for you. As long as you're able to have it every day, it gives you very good high quality protein that you don't have to eat buckets of dals. Okay, so you can do with small quantities of your non-vegetarian food. Red meat is probably not recommended. Fish is good. It gives you omega-3, it gives you a whole lot of other things. So fish is good as long as you're not frying it. So anything that is steamed, boiled, or in curry can be taken, either chicken, fish, or egg. The red meat, better to avoid.
All right.
Here,
Moving back.
can I add something? Just a line. So I think non-veg is also a concentrated source of fat as well. So I think portion control is a very important here. So whatever the non-veg we are taking, I think the portion control and the adequate amount is very crucial. So that should be always in mindful.
Okay,
True.
great. So moving ahead, there is a lot of, questions about, genetics and, like if parents have, grandparents have, and,
If a single parent has, your risk is 50%. If both your parents have, you have a 90% risk of developing diabetes in your lifetime.
yeah, and then maybe the preventive measures as much as lifestyle probably would be
Preventive is just weight loss. See that you don't gain too much weight. If you do that, then you can prevent as far as possible.
all.
So don't gain weight. That is the only, be within the normal BMI.
Okay, so and how to manage fluid intake during diabetes nephropathy?
It depends on the stage of nephropathy. In earlier stages, there's not much fluid. You must take fluid and protein. As the stages come, then it'll be usually case based. Usually 1.5 2 liter restrictions will be that. It totally depends on the case.
All right, and I'm sure there will be more and more questions as I think we won't be able to stop. Dr. Anjana, just maybe two, and then we can just
I'm
wind
happy
up.
to take the questions, whatever.
Okay, go ahead. Then we will be happy to really do that. The question on like say particularly some professional wants to know some organizations to get diabetes consultant certification, and I'm sure you could yeah.
Well, we do individual certifications. So you could apply to the programs. It's called CCE BDM. Depends on what you want for diabetes. It's called CCE BDM. You can apply for that. The organization, I think you can try RSSDI. I'm not terribly sure if they're giving, but you could try.
And then in terms of your expert experience, which is more effective when compared to continuous monitoring on infusion pump or OHA?
Sorry, continuous monitoring of glucose?
Yeah, and the pump on the infusion pump or the OHA?
Should you continuously monitor if you're on the pump or the OHA?
Yeah.
So things like the 780G will not work without the CGM. It talks to each other. It works based on so it is mandatory. Older versions of the pump, it's better to use it, but you don't have to. The pump will work without, but then you run the risk of hypoglycemia quite a lot. On OHAs, unless you have certain forms of diabetes like brittle diabetes and things, generally we don't use CGM. But again, it's case to case. It depends on the case and what the issues are around that case.
Okay, so maybe in terms of intermittent fasting, there a lot of these fat diets that you kind of mentioned, and is intermittent fasting and low carbohydrate diets and reversing insulin resistance in type 2 diabetes?
So first I'll do the low carbohydrates. So I was saying there was no need for very low carbohydrate or low carbohydrate diets. They do have side effects. So if you're just able to bring it down to 50%, you should have metabolic benefit. Things like intermittent fasting, do they work? It depends on what they work for. For weight loss and glucose, it does work. But the problem is, it'll work for the period of time that you do it. And when you stop doing it, you could, face a rebound, which is a bigger problem. So it would rather, for in general, with any of these lifestyle things, rather than doing large or big things for short periods of time, to small changes for long periods of time. That is what is going to. So small things that you can do. Make, if you're eating 3 or 4 chapatis, make it 2. And do small things that you can do for the rest of your life. Instead of doing some massive liquid diet or intermittent fasting, you'll do it for 2 months, 3 months. Then what will happen? You have to live your whole life, right? So then do something that you can sustain for a long period of time, and you will find that the metabolic benefit is there. Otherwise, you'll cycle, and especially if you're a woman, over time, anyone, man, woman, over time, you will see that there is an increase in all of these things.
Okay. Any other specific this one? I think in terms of the questions, we are like about done. There's a lot of this, where you talk about different kinds of this one, and in terms of diabetes itself, and that there's going to be a huge, number of people that we will have to be really working, and even if we have about 20% who gets nephropathy and this one. So what as the responsibility? So we have hospital management students and people who are going to be really communicating to a lot of communities and talking and various programs. So the burden of diabetes or the other organ failures that is going to happen. How do you think India should be really looking at, and what should the public health strategies are?
That's a very good question. I think the primary one is education. First, people should know what to do, and second, start doing it. So I know they're two different things, but at least we can start with educating people, especially with a massive population in rural areas. There are too many myths and too many, fears that people don't. In diabetes, luckily, because it's a lifestyle disease, a lot of it is eminently preventable. It is our lifestyle that is causing all this, and that can be reversed. So simple things, right? Just decrease that carbohydrate intake a little bit more, increase the protein and fiber, do everyday walking. And 99% of people do walking when you say exercise. So just do a 60-minute walking without fail every day in the week. These are very small things. It can be done by anyone, anywhere. It doesn't cost anything. So that if you do that itself, 50% risk reduction. That's what we have shown. So there are actually there's nothing big that you have to do, right? There are smaller things that you can do. And it does have big impact. So for the larger population, this would be the messaging. However, having said all that, there are people who will progress in spite of all this. There's subtypes and all that. Once it reaches that stage, better to go to a doctor who will, guide correctly. But for a public health messaging, that I cannot overstress. The other thing that I didn't talk about is stress. Right? So that is a huge killer these days. So doing these 3 things, diet, physical activity, stress management, 50% of diabetes can be prevented.
Okay. Anything else, Dr. Jyoti? Yes.
Yeah, our students, they are interested that how they can join that Tandav every
Yes.
Friday.
So there is a tandav.in,
Okay.
tandav.in. So that I think my slides, maybe I didn't, I can't remember now if it was there. They can just join tandav.in. There is a registration. The classes are on every Friday. So Friday evening, once a week are our classes. We have both offline and online classes, late evening on Friday.
Okay, so that will be one dedicated day where our student can ensure the physical activity.
Yeah, definitely.
Okay. Yeah, so shall I start proceed for the vote of thanks, ma'am, with your permission?
Yeah, I think,
We've already exceeded.
There are more questions on drug adherence among diabetes, techniques to use for, that one last question, and then you can kind of, we can wind up. Yeah.
What is it? Drug adherence.
It is like, what are the techniques you use for drug adherence among diabetes?
I think the most important thing is education. So with complex regimens, it of course depends on the regimen. The simpler the regimen, the easier for adherence, number one. Number two, there is a big literacy component to this. So the more literate or educated a person, the easier to explain. The more uneducated, they tend to fall off this very easily. They don't understand the regimen, they're complex. I think frequent follow-up, regular, you tell they need to hear it multiple times. So what we do is, once doctor will tell, one dietitian will tell, once pharmacist will tell, same thing, you hear it multiple times from multiple people. We do have follow-ups in which we, ask them whenever they come, and we do phone calls, etc. Drug adherence is a problem. So we have to, it depends who you're dealing with. Lower socioeconomic status, you have to follow up very regularly with them because they fall off easily.
Okay, all right. Thank you, Dr. Anjana. This was amazing, and we are very fortunate that you accepted our invitation. And this has been whether it is on the technical part of it or simple behavioral change aspects. I think you really got it right on dot, and that obviously that's what is expected of your person of your stature. And really thank you from IIHMR. And over to you, Dr. Jyoti.
Yeah, thank you so much, ma'am. I mean, just a one thing which we have, like in army hospitals, there is a one strong message from one of the students that the treatment guidelines are they start insulin at a very like low HbA1c. I mean, there are some guidelines for that. But whereas the general practitioners or endocrinologists, basically, they start insulin after like 10 or 11. So is there a standard set of guidelines, or they just want to, like, because medications has a side effects also, and insulin is better than medications? I mean, these are some justifications by them. So is there, what is your,
there is something called as early insulinization. So there is evidence to support that in early stages of disease, when someone has just been diagnosed with diabetes, if you give insulin for the short term, 2 months, 3 months, something like that, it has the capacity to preserve the beta cell for longer. So we do it. We do 1 month insulinization, and there are people who do it. But then you don't have to continue that for a period of time. Medicines don't have that many side effects. They are actually safe. There's lots of fear around medication. If you give the right medication for the right person, that is the challenge. If you do, like, it's like a gunshot, generally you hit everything you give, then there'll be problems. If you know what to give for whom, they're quite safe. But we also follow that, actually, where we do try and give early insulinization for certain people for a period of a month. And then once you stop that, the durability, the pancreas recovers, and it will stay that way for 20, 40 years.
okay.
So
Yeah.
it depends on the case, I guess.
Okay. Thank you so much, Dr. Anjana. I think we are very grateful to you for accepting our invitation, and for, like, we have already extended half an hour. So I think for that, apologies for that. With this note, I would like to invite our Dr. Deepa Shri for like a quick vote of thanks. She's assistant professor at IIHMR Bangalore. She's an Ayurvedic practitioner, and she's also an alumni of IIHMR Bangalore. So with this, over to you, Dr. Deepa.
Dr. Jyoti. As we drew our discussion to a close, I take this opportunity to heartfelt thanks to all of you. I would like to specifically thank our speaker, Dr. R.N. Anjana. Ma'am, your expertise and perspectives have added an immense value for our discussion. The statistics you provided, the ABC highlighter for a diabetic patient is a really an eye-opener, which is an easy to follow. Appreciate your efforts on using the technology, ma'am, that Diala, and Diana. Your contribution have really sparkled ideas and fostered dialogues that will guide us for the days to come. What I understood is be consistent. Prevention is the two mantras what we have to follow in diabetic care. And a big thank you for our director, ma'am, Dr. Usha Manjunath and Dr. Jyoti, for creating this discussion and helping us to know and enrich us with the knowledge. And I would like to thank our IT team for the seamless support for the flow efforts, and also my participants who have guided us with their thoughtful, provoking questions. That was also interesting to listen. Reflections and enthusiasm. Let us take the idea shared today as a foundation and continued collaboration and innovation. Thank you all once again. I would request those who have participated in this program, if you could enable your videos, we would like to take a group photo which we can share with you all of the participants. And I'm requesting everyone to enable their videos and my IT team to take a group photo.
Thank you so much for having me. It was an absolute pleasure. The greatest thing that we have is when people, want to know, and students are asking questions, it's the biggest motivator for us, isn't it?
Yes,
So
ma'am.
thank you so much. I was really happy to hear the questions that came from so many of them.
Yeah. I would request my IT team to take a few screenshots and request the participants to enable their videos.
Okay, ma'am.
Arun, can you take out this view and put a gallery view?
Yeah, yes.
Yeah. Regarding the certificate, we will be providing you the link for a feedback. Do give us a feedback about the program, and the e-certificate will be mailed to your respective email IDs. Yeah.
So we can give just a big smile.
Yes.
Okay.
Yeah.
We can
Dr.
see all.
Jyoti, I'm happy to have the feedback as well.
Yeah, that's very important. So we will be taking the feedback, and then definitely it will be like 360-degree approach. So where I'll be communicating the feedback to you.
Super.
Yeah.
Yeah, and I think all of us walk away with a simple resolution, and hopefully we will keep it. Reduce the little bit of the amount of carbohydrate that we eat, and then some regular exercise, 60 minutes a day. Thank you. Thank you.
Thank you so much, everyone. Thank you so much, Dr. Anjana.
Thank
The
you,
pleasure.
ma'am.
Thank you so
all of
much.
you.
Thank you. Thank you.